thank the meeting planners and the people here for inviting me to present our study. It's titled a Phase 3 open-label randomized multi-center study of Eribulin versus capecitabine in patients with locally advanced or metastatic breast cancer previously treated with anthracyclines and taxanes. And it's a privilege to present this on behalf of my co-authors. Here are disclosures. So Eribulin is the only chemotherapeutic agent with a demonstrated survival benefit for patients with heavily pretreated metastatic breast cancer. This was initially demonstrated in the EMBRACE trial, which was a previous Phase 3 trial evaluating Eribulin in women with heavily treated breast cancer. And this led to the FDA approval in the U.S. of Eribulin in women in the third-line or greater setting of metastatic breast cancer. Capecitabine is a widely used therapy in metastatic breast cancer, including the first, second, and third-line settings. So Eribulin is a novel chemotherapeutic agent and has a unique mechanism of action. It is a synthetic analog of halochondrin B, which was actually originally isolated from a marine sponge a number of years ago. Our study design is a relatively straightforward Phase 3 global randomized trial evaluating Eribulin versus capecitabine, as outlined here. Important inclusion criteria listed here. Women had to have had less than or equal to 2 regimens, chemotherapy regimens for metastatic breast cancer, less than or equal to 2 regimens in total. Patients had to have received a prior anthracycline and taxane at some point in their illness. Our co-primary endpoints, importantly, are overall survival and PFS, progression-free survival, and our secondary endpoints are listed here. And I just want to highlight a couple of points. This is a slide summarizing the patient and disease characteristics in terms of the 2 arms. The study was well balanced, as we'd expect. I should mention there were approximately 1,100 patients enrolled on the study. This was a very large trial in metastatic breast cancer. About 50% of the patients had received 1 prior regimen for metastatic disease, 20% had had no prior therapy for metastatic disease, and about 30% had received 2 prior regimens. And if you look to the bottom of the table, an important point is we have about 25% of patients overall who have triple-negative breast cancer. As you just heard, triple-negative breast cancer is a group with unmet need. It is a more aggressive biology. It's a group of patients that historically have not done quite as well. And this translated to a total number of 284 patients in this study with triple-negative breast cancer. So this is an important slide. This is our primary finding, in which we see the overall survival curves. So the median overall survival for Eribulin is 15.9 months versus 14.5 months OS for capecitabine. The hazard ratio is as listed, and the p-value is 0.056. So there's an early separation of these curves in a trend, but it's important for me to point out this is not statistically significant. So there's not a statistically significant difference for Eribulin versus capecitabine. And this slide just highlights one of our secondary objectives, which is 1, 2, and 3-year overall survival. And again, numerically, Eribulin at each of these time points was slightly better, but these findings are not statistically significant. PFS was essentially identical in both arms of the study. It was approximately 4 months, both on independent review as well as on investigator review. Response rates were very similar as well, and you see here the response rates based on independent analysis as well as investigator review, as well as the overall clinical benefit rates at the bottom of the table. I'm going to skip these slides in the interest of time. And I'm going to move on to side effects. And an important point here is the side effects that we saw in the study were as we would expect based on prior data. So there was a higher incidence of neutropenia in patients receiving Eribulin. Approximately 45% of patients developed grade 3 or 4 neutropenia receiving Eribulin. But the clinically important point is the incidence of febrile neutropenia, which was low and acceptable at 2% for patients receiving Eribulin. There's very little myelosuppression with capecitabine, as we expected. And in terms of non-hematologic toxicities, again, we saw findings that were not unexpected. We saw a higher incidence of hand-foot syndrome. There's approximately 45% incidence of hand-foot syndrome, which is one of the known complications of capecitabine. We saw a somewhat higher incidence of diarrhea, nausea, vomiting, or emesis. The incidence of fatigue, I should note, was actually comparable in both arms. In contrast, in terms of non-heme toxicities that were worse for patients receiving Eribulin, the primary one was peripheral neuropathy, which is, again, a known and expected side effect associated with Eribulin. But the overall incidence was reasonable, with a 13% incidence overall in a approximately 4% incidence of grade 3 neuropathy, which is more severe neuropathy. This is an important slide that I want to bring your attention to. This is our subset analysis. So these were pre-planned subset analysis looking at specific groups. And at the bottom of the table, you'll see the triple negative subgroup, which I mentioned earlier. In this group, there was a greater trend favoring a benefit of Eribulin. The hazard ratio here is 0.7, approximately 0.7. The difference in the median overall survivals are approximately 5 months favoring Eribulin. Again, this is not statistically significant, but we felt this was an interesting trend. And you'll see also in the HER2 negative subset, as well as in the ER negative subsets, trends that are somewhat more favorable compared to the overall study population. So in conclusion, we do not demonstrate a statistically significant superiority of Eribulin versus capecitabine in regard to either overall survival or PFS. The median overall survival for Eribulin is 15.9 months versus 14.5 months for capecitabine. However, pre-specified exploratory analyses, we feel, suggest particular patient subgroups may have a greater therapeutic benefit, warranting further study. These findings are not definitive. And finally, Eribulin and capecitabine have similar overall activity in this trial that included patients in the first, second, and third line setting. And the side effect profiles are consistent with known previous data in the side effects of both of these medications. Thank you.